Welcome to Stand Up for Doctors. I'm your host, Kim Downey. Thank you very much for joining us. I'd like to welcome Dr. Paul DeChant and Dr. KateTulenko. Thanks for joining us today, Paul and Kate.
Glad to be here.
Pleasure.
I'm very happy to have you. And by way of a brief introduction, I'll have you introduce yourselves in a moment. Dr. KateTulenko is a health workforce expert, social entrepreneur, Presidential Advisory Council member, and speaker. And Dr. Paul DeChant is a speaker, coach, author of Presenting Physician Burnout, leader of high-performing teams, and Dr. Zero for this work that I'm doing. So I feel like I need to take a moment to explain that. So I've had several cancers and several cancer surgeries, and after my first two, I found Kevin MD, and I was reading all the articles. I was concerned about doctors. I was reading the physician suicide statistics, and I wanted to do something to support my own doctors because I had a team of doctors that I care deeply about. So I tried to reach out to our local healthcare system, and the first few people or departments I reached out, I didn't get anywhere. So I'm like, sometimes you got to go towards the top. So I reached out to the chief physician executive, and he forwarded my email to Paul because at the time Paul was working with our local healthcare system. So Paul offered to chat. So we had a Zoom. So that was May of 22. And it was then that you sent me your book. And for reasons that aren't totally unknown to me, it didn't really, go anywhere. I tried rather desperately for the next year and a half to make an inroads in my local healthcare system. But once I got on LinkedIn about a year and a half ago, the doctors were telling me that they thought I was meant to, make a bigger impact. And I didn't want to hear it. I only wanted to help my own doctors. But my physician coach, Dr. Michael Hirsch, says, whatever happens was supposed to happen because that's what happened. And if I was just doing things locally, we wouldn't be having this conversation today. So I'm just grateful for that opportunity and happy to have you both on. And one more thing I'll say is today is my 1 year podcasting anniversary. A year ago today, on a Halloween, it is. I introduced
Congratulations.
Dr. Todd Otten. And interestingly, at that point, we had shared about 400 connections. And I asked Paul in the episode for him to guess who was the very first person I suggested he connect with. And guess who that was?
Paul.
Yes. Paul, it was you. And I
How do
say
you
that
know?
in the episode. So now, exactly 1 year later, to actually have you on, it's, kind of like a full circle moment. And I just think that's really cool. And I'm happy to introduce you to each other. So today we'll be talking about evidence-based ways to address physician burnout. And I always start by asking what you'd like our audience to most know about you. You can include hobbies, whatever you want. Kate, would you like to go first?
Sure, yeah. So I'm a physician and health workforce expert. I'm the founder of Corvus Health, is a health workforce firm, and I'm also a adjunct professor at the Johns Hopkins School of Public Health, where I teach health workforce planning and management. I'm married. My husband and I live with our two daughters in Alexandria, Virginia. We love hiking and being outdoors, and on weekends you'll usually find me gardening.
Oh, well, that's terrific. Thank you for that introduction. And Paul?
Thanks. First of all, it's just a pleasure to be here and gosh, all that background about this being the 1 year anniversary. Very cool. Um, so I've spent 25 years practicing as a family physician, slowly burning out, wanting the autonomy to fix things in my workplace. Ultimately, I became CEO of a 300 physician group, and during 4 years, turned that group around on the theory of fixing the workplace, not fixing the workers. And we got recognized as the top performing among 170 medical groups across the state of California 2 years in a row by Consumer Reports and the California Health Performance Information System. For the last 10 years, I've been coaching health system leaders around the country on how to pursue similar activities and similar outcomes. And it's been a bit of a challenge because there is so much going on, particularly 4 years ago with the pandemic. It threw everything into a bit of disarray. But I think we're really at a point now where we have this opportunity to truly impact the workplace by combining intentional workflow processes, leadership processes, focused on servant leadership where we empower people on the front lines and align everyone around values that bring meaning to the work, and incorporating AI and other technologies thoughtfully into the process. So that's my passion now, is to do that. I do consulting, I do coaching individuals on turnaround leadership. I just became an adjunct professor at the University of Colorado's Graduate School of Business. I'd actually gotten my MBA there, so it was quite a pleasure to come back and do that. I just moved to the central coast of California, the San Luis Obispo area, for people familiar with that. Married, our kids are grown. And at this point, we have no pets, but we're contemplating that sometime in the near future.
Well, I love that. Congratulations to all that, and especially the potential future pet. It'll be one lucky pet. And so as we start, again, our topic discussion is going to be evidence-based ways to address physician burnout. And I'm hoping at some point during the discussion, because there's so many layers to it, from the healthcare system level to the leader level to things individual physicians can do, and even to the responsibility that boards have. So this will really be like an appetizer, right? Because this conversation could go on for hours. So we'll share some, and then I'll obviously put in the show notes, and I'll have you say how our listeners can get in touch with you to discuss it further. But as we start, Paul, I wanted to share just one sentence, because this book, I started dog-earing pages from the very first paragraph of the introduction, and part of what you quoted, a physician in his mid-40s, in just one sentence says, "There is no quiet minute to think about the patient." And that so totally resonated with me as a physical therapist and going through all the changes myself with the EMR. And I just thought that was like really, really powerful. And if you're in this field, you understand that. Kate, would you like to start the conversation?
Sure, yes. I wanted to talk a little bit about the process of how health systems can think about physician and health worker burnout. And although I think we will be referring to physician burnout throughout this talk, it's really all health workers that are burning out. And they often just think of the parts like maybe physicians leaving or being unhappy, but you need to calculate the total cost of burnout, which includes having to pay for locums. Most hospitals pay tens of millions of dollars a year for locums, because you usually pay 2 to 3 times for locums than you do for an employee. The cost of recruiting new workers, which is often 1 to 2 years of salary. The reduced productivity to get someone up to speed is estimated that it takes a new nurse 6 months to get up to speed in productivity compared to a nurse who's been there a while. The cost of poor quality care, the cost of turning away patients because you don't have the staffing, the cost of readmissions because people weren't properly cared for, weren't properly followed up, cost of lawsuits. So there are all these different costs. And you look at that and say, well, it's costing us literally hundreds of millions of dollars a year. Perhaps you could take that money and put it into redesigning the workforce so that people don't burn out. And what hospitals need to do is a systems change. They can't just do these band-aid approaches, the yoga, the pizza nights, things like that. You have to look at your healthcare team. How can you make it more efficient? Can you add more workers? It was quite interesting to see that when 75,000 Kaiser health workers struck last year, one of their main requests was that Kaiser hire new workers and fill the vacancies. And so Kaiser's committed to hiring 10,000 new workers in the system. And that shows it's not just about money, it's about actually having teammates to help you with your work. And if that physician that you quoted had 1 or 2 fewer patients because there was another physician, they could have that quiet minute to do that deep thinking and not just do sort of like what we feel are knee-jerk differential diagnoses, because we don't have the time, to really contemplate, what's going on with a patient. And also I want to say that, the U.S. is a market economy, right? And so we have a free labor market. But we have significant market failures in our labor market. Most of this is occurring around how we regulate health worker education. And it has become so expensive to train health workers. It's estimated it takes about $1 million to train a physician and maybe 100 to 200,000 to train a nurse. We have priced ourselves out of training enough healthcare workers for the U.S. economy. That's why we're reliant on bringing in tens of thousands of health workers from some of the poorest and sickest countries in the world, where we then significantly damage, their health systems. Just to take India as an example, we get a considerable number of physicians from India, and there's often a misperception, including actually at the highest levels of medical leadership, about the healthcare situation in India. If rural India were a country, it would have the single largest health worker deficit in the world. So they have a huge shortage of health workers who were actively damaging these health systems. And so what the US government needs to do, or the states, is to address these very specific market failures. So one of the market failures is that a nurse actually takes a pay decrease when she goes from being a clinician to being a nursing professor. So we have to increase their wages. And so one thing South Carolina has done is they align tertiary education funding in the state with open jobs in the state. So if there are no open jobs for, ancient Greek, specialists, they've reduced the ancient Greek department budget. But if there are 5,000 open nursing positions in the state of South Carolina, they increase the nursing school budget. That's what every state needs to be doing. Just to give an example, and I'll stop there and let Dr. Paul talk. That's a little bit of the challenges that we're going through.
Sure. So two things I want to say quickly is thank you very much for sharing what South Carolina is doing, because I've been on Kevin MD multiple times, and he'll say, we've been talking about burnout for years. Do you think the needle is, is moving? And we need to talk about things that we can actually do instead of just talking about it, right? And figure out what is working and connect all those dots. So that's great that you shared that. And Paul, as you respond, if you also want to take a moment to define the difference between burnout and moral injury, because there's some doctors who turn off when they hear the term burnout because they feel like it's moral injury. And I think sometimes it's both. And I feel like when I was working, I experienced both, and there is a difference.
So that's a great, so we can talk a lot about that. First of all, Kate, I really appreciated the concepts of how expensive it is to train. When we think about, we spend $1 million bucks training a doctor, and so many physicians are turning away from medicine as soon as they finish med school or training, or they're reducing their FTE. And just we think about the impact of that, it's pretty astounding. We have to create livable ways for people to work a full-time equivalent as their physician after we've invested $1 million in training them. Especially they've invested themselves somewhere between $300,000 and $500,000. But so Kim, this issue of moral injury versus burnout, it's one that's getting discussed a lot, and I really don't understand why it's thought of this way. I do understand it, how people don't understand burnout, but there really is no difference between moral injury and burnout. Burnout, as defined by, it was identified 40 years ago, those three dimensions of burnout, of exhaustion, cynicism, and inefficacy, by researchers Christina Maslach and Michael Leiter. They also identified 6 drivers of burnout, which they describe as job-person mismatches, and they include work overload, no surprise, which drives exhaustion. But they also identified, and most people think that's all there is to burnout. And even people who are leaders in the moral injury movement think that's all there is to burnout, is I'm overloaded, I'm exhausted. But in fact, 40 years ago, Maslach and Leiter showed these 5 other drivers that include a lack of control and autonomy, insufficient recognition, appreciation, and reward, breakdown of community connection and collaboration, absence of fairness, and conflicting values. And in particular, absence of fairness and conflicting values are intimately involved in moral injury. So when people are pursuing, and so we've known this for 40 years, and as people are pursuing this concept that somehow moral injury is different than burnout, I think they're taking a very limited view of burnout, a very transactional view of burnout, when in fact, it's actually a very broad subject. And if we're going to impact the work overload, which is transactional issues in the workflow, we need to address the corporate culture, which corporate culture is driven by those other 5 drivers of burnout. Control, reward, community, fairness, and values have everything to do with how someone leads. And whether you're leading a team as small as 2 or 3 people or as large, you're the CEO of a 20 to 30,000 person organization, if you lead in ways that exacerbate those values, if you micromanage, you drive cynicism, you create moral injury, but you have an option. And most people don't know any other way to lead because their mentors have always led that way. And they feel under the gun to hit these performance metrics that are set for them. But there is this other way to lead through servant leadership where we empower people on the front lines, align them around the values that bring meaning to our work, address moral injury in that way, and create fantastic engagement. And I'd love to see the conversation move away from this false dichotomy of moral injury versus burnout and have us all come together and work together on it because we need to change leadership in order to reduce the work overload. And so that's my plea. As you can tell, it's something I'm pretty committed to because I think we waste our time trying to focus on this. What we need to do is really focus on how do we help leaders understand this so they can lead differently. There's such a level of mutual distrust and disrespect between frontline clinicians and senior leadership in most healthcare organizations these days. And it's so damaging and it's so limiting. And then we end up with the downstream impacts, like all the financial impacts, the lack of staffing, and all those other things that Kate was referring to, which are crucial, and we need to be addressing them efficiently and effectively.
Well, thank you so much for kind of dispelling the burnout, moral injury, myths. And what I hear from physicians is I feel like they think if you say burnout, they take it as individual factors or putting the onus on them. But if you say moral injury, they attribute it more to system failures and they feel like, that's where the emphasis should be on. So I feel like you really just did a very good job of explaining that. So thank you. So Kate, anything you
Well,
want
you know
to
what?
go ahead?
Let me just follow up with that really quick, and then Kate, I'd love to hear your thoughts. So you're absolutely right, and I think that's the other challenge is people think if they hear burnout, they think it's their fault. Like, there's a problem. The problem with burnout is the workplace. It's not the worker. And they hear burnout and they think the problem is them. And it gets reinforced when you're offered resilience training as the way to deal with burnout. Healthcare workers are the most resilient people in the world. It's offensive to only offer resilience training as the answer to burnout. It's necessary, but resilience training, because things are such a mess. But if you stop there, then it's really quite offensive. And I understand why people feel like that. My worry about moral injury is it makes it sound like we're all victims. And if we're in a victim mentality, we're not going to be able to fix the root cause of the problems. So that's where the term moral injury to me becomes more of a challenge because it's how do we then move beyond that and actually address things positively and fix the root cause challenges.
Absolutely. I'll let Kate speak to that now. And again, the word resilience, that's another word that's turning physicians off these days, right? But it's not an either or, it is both. Exactly what you said. As while things are so bad, there are things that individual doctors can do, although that it can't stop there with just trying to make physicians more resilient. So that was an excellent point. And also speaking to the point, they're related is if you don't want them to feel like victims, and again that they do have some agency. So Kate, anything you want to speak to what Paul said and also how physicians can have a sense of agency?
Yes, we definitely do hear that most health workers, find resiliency training, offensive. They feel that the money spent on that should actually be spent on fixing the real problem. The best analogy is you're all in a leaking boat that's sinking, and instead of taking the funds and actually fixing the leak in the boat, you either teach everyone to swim, you're teaching yoga, or you give everyone life preservers, rather than actually fixing the problem. I do want to say on the issue of burnout and moral injury, I do think that burnout is a broader umbrella and that moral injury is a subset of that. And I think that the reason people pick moral injury up is it's very distinct in healthcare, because moral injury is when you have that complete different set of values, that you are practicing in a system that is hurting everyone in the system. And currently, the US healthcare system is hurting the patients. It's hurting the health workers, and actually, frankly, it's hurting everyone in the US, because the US pays more per person for healthcare than any other high-income country, and we get the worst outcomes. I've been familiar with moral injury for over 25 years because my college roommate, her father was Dr. Jonathan Shea, who was a psychiatrist working with Vietnam veterans and teaching them the Iliad and the Odyssey. And their identification with these warriors, in this classic, Greek piece of literature, is what led him to define this sense of moral injury. When you are asked to do something as part of your sacred work that goes against what you have sworn. I mean, physicians and nurses, we take an oath to protect patients, and then you're put in a system where you're directly hurting patients, and there's a solution, and people aren't implementing the solution. So that's what I wanted to say on burnout and moral injury. And to go to more of the solutions, we know, as Dr. Paul indicated, we need to do workflow redesigns. We need to add new types of healthcare workers. I'm old enough to remember when they first introduced phlebotomists into hospitals. Phlebotomists are specialty health workers trained for about 6 months to, I think it's 6 months, 4 months to 6 months, do nothing but draw blood. And I'm a pediatrician. When I was a resident, before I did any of my other work, I had to run around on my patients and draw their blood, which is just not a physician level skill. And it can take a lot of time. And if you have like 10 patients, it can literally take an hour or more. And the phlebotomist just saved all this time, and you pay them a fair wage, which is a fraction of what you pay a physician to do. And since they do nothing but draw blood, they get better at it than the physicians and nurses. And so that's a wonderful example of introducing a new type of worker. Also, on the workflow redesign, one of the biggest errors made in the US healthcare sector in the last 20 years is when electronic medical records were introduced. That was a huge addition of a new type of work to a physician's schedule, and nothing was done to modify that schedule. So you used to just be able to write as you spoke to your patient, and maybe the record wasn't so good, but you were able to make eye contact, and you got your work done very quickly. Now with the EMR, we know, and there have been dozens of studies on this, physicians spend more time looking at the computer and with the EMR than they do looking at the patient or even with the patient. And so we can help with this by either hiring scribes who are human beings, or now increasingly AI scribes. And that's the type of workflow redesign or the team redesign that we need. Also, we need to do intentional planning to give you intentional workforce planning. Pediatrics has always been a little bit on the cutting edge of workforce planning because pediatricians are reimbursed so little compared to adult medicine that would have had to be very innovative. And a lot of the nurse practitioners and other types of health workers were introduced in children's hospitals first. When I was a pediatric resident in the early 2000s, we actually at our hospital, the Children's Mountain Medical Center in DC, had a committee of non-physician providers, and I was the resident member of that committee. And we looked at how can we make our teams more efficient. That's the type of intentional plan you need. And another thing that Children's did, which immensely improved our quality of life, if you were the resident, the senior residents staying in the hospital overnight, like literally in charge of every single child in the hospital, they would have someone called a night float who came in at like 9 p.m. and who would admit all the new patients in from the emergency department. So you wouldn't have to worry about them. You just had to worry about like the 300 children that were in the hospital. And that night float enabled people to get even just an hour or two of sleep a night and just revolutionized it. I know multiple people who, as residents, had car crashes driving home after a 36-hour shift. And luckily, that type of thing stopped after night float. And I'll give you an unfortunate example of not planning in my pediatric residency. The majority of pediatricians are women, and there was not a plan for maternity coverage. No plans whatsoever. A resident got pregnant and had a baby. What are we going to do? No plan whatsoever for coverage. Everyone else just had to pick up the slack. So that shows you how there's a failure to plan. But I'll stop there and see what Dr. Paul has to say.
Thanks. So I just want to say that you're both, healthcare leaders, and I think you both traveled internationally and such. So, how often are healthcare systems reaching out to you for help? Like, I'm an inpatient person. I want things to change, better and faster, and so do a lot of other people. So how can we speed this up, and how can we make real changes and make more healthcare systems reach out to you and really care and not just check the boxes? So anything, Paul, you wanted to say to Kate and to speak to what I just said?
Yeah, I think what Kate started talking about, which is the actual cost of burnout, which is not it's poorly understood in most healthcare C-suites because it doesn't show up on typical financials. The investment that's made in preventing burnout is something that shows up on a P&L statement as an expense, but in fact, it should be considered something on the balance sheet. It's equivalent to purchasing an MRI, which you amortize over a number of years and you start making money on right away. And the expense you lay out for workflow redesign at first doesn't really show the benefit down until a couple of years down the line when those benefits are huge. Secondly, the lost revenue from turnover doesn't show up anywhere on the financial statements. And there's not a good way to do that. There are some new formulas out that can help. The AMA, which actually has committed a lot of its resources to addressing these issues, and has got a great leader in Dr. Christine Sinsky, who's leading the AMA efforts in this. They actually have a calculator on their website on the cost of burnout, which it can help people get a sense of just how significant this is and how much opportunity there is to make moderate investments that can really pay off with a 5 to 10x ROI down the line as people see this. So really, I think to get systems activated, we've been appealing to people's better nature and to the factors of depression and suicide and all those things for over 10 years. It has not moved the mark. Financially, as places are struggling a bit more, I think that may help move the mark. But there are just the external forces that are pushing, that are driving a lot of this are so significant. And hospital administrators are, they're, as much as the ones who realize what's going on, may have compassion, may have a desire to do something, they're also struggling just to keep the doors open and the lights on, and they need to understand the impact. One other thing I think that can really help is to get senior leadership, for those who are interested, to actually spend time on the front lines, to shadow clinicians while they're working, doctors, nurses, even therapists, technicians, receptionists, to see the challenges, the barriers and frustrations that we all run into while we're trying to provide this great patient care. When they actually understand that, because so many are far enough removed, they don't understand the actual operations. They don't understand the impact of the way that things are poorly designed and could benefit from redesign. Once they witness that can be a great motivator to help people move forward. So that's one of the things I really help promote with leaders. Really two things. One is get out there and see it. And secondly, understand the finances. And we put those two together, hopefully that can spur real action and investment in what we need to do.
Well, thank you. So I'll you could each go around one more time. And Kate, if you have anything to speak to, how do we get the systems activated? And it's a largely physician audience. Is there anything you suggest physicians do? And we haven't really touched on boards, but should the public be reaching out to boards and holding them accountable? Whatever you wish to speak to.
Sure. First, I want to talk about some of the solutions. We see a lot of private health systems either starting health professional schools, such as Mayo Clinic, or acquiring health professional schools. HCA acquired Galen Nursing School a couple of years. So we talked a lot about supply chains during COVID. Health workers are the ultimate product that you need a supply chain. So every health system has to secure their health worker supply chain by either having a health professional school or having relationships with health professional schools that they help expand and improve. So that's thing number one. Two, what's going to make it change? I think at some point we're going to need a Libby Zion event. Libby Zion is a young woman who died in New York because she was being cared for by a resident physician who'd been awake almost 24 hours. And her death and the following lawsuit led to the rule that residents can't work more than 80 hours a week. I have a general rule of thumb that if you can't do something to a prisoner of war, you probably shouldn't do it to a health worker. But unfortunately, that's not always the case. I think we're going to need something that bad. Like we already have had a nurse get a criminal conviction in the U.S. because she made a medical error while being very busy that damaged a patient. That is unprecedented. Usually you just take someone's license away. This is a criminal conviction. So I think we're unfortunately moving towards that. What physicians and other health workers can do help their leaders in the hospital, in their boards, in their associations know the data. For every additional health patient that a nurse has, the mortality rate of all of her patients increases by 7%. There's also incredible data on looking when hospitals reduce staffing, that the readmissions increase, the surgical site infections increase. There's a lot of data to show how it hurts patients as well. And I think once patients find out about this, hopefully they will join us in this advocacy.
Well, thank you. I see an article coming where we share some of this data and we spread it broad and wide, and we might get on that after this call. Paul, what are your parting words?
First of all, I love the concept of the health worker supply chain. I hadn't thought of it that way, but I agree. There's lots of places that have done a lot of work along those lines, and it's absolutely valuable. I think just from a real practical standpoint, what can an individual physician do? You think you can feel pretty powerless in this. We can actually address some of those other drivers of burnout individually. That whole concept of insufficient reward, recognition, appreciation. If you every day thank somebody for something they did that really helped you out, it's not going to change the world, but it'll change your local site and start to build some positivity. It's not going to solve all the problems, but it'll help everybody's day go a little bit better. So that can start to make a difference. And then I'll go back to what I said before. For leaders, getting out and shadowing clinicians while they're working is invaluable. I stopped seeing patients when I became CEO because I thought I wasn't seeing patients often enough to be a good clinician. But I didn't stop. I then substituted that with shadowing doctors in every different specialty. So instead of just knowing the pain of being a family doctor, I got to see and experience the pain that the pulmonologist went through, different than the orthopedist went through, different than the rheumatologist went through. And understanding that then helped me to help everyone more effectively. And it's so vital to be doing that. So the more people can connect, appreciate each other and understand each other are key steps to get started in this process.
Well, thank you. I love that so much. And I'm all about that, gratitude and thanking people and connection. That's where the healing's going to occur. Colleagues with each other, system leaders and physicians, doctors and patients, all of it, just taking back that human connection with each other. So thank you very much. I knew this would be a great conversation, and it was. So how can our listeners get in touch with you, Kate?
For me, they can reach out via LinkedIn, or they can contact me via email at KateTulenko, which is my first initial last name, at Corvus Health at CORVUS health.com.
Well, thank you, and I'll put that in the show notes. And how about you, Paul?
So LinkedIn, it's always great. I'm also have my website, pauldechantmd.com, and my email is paul@pauldechantmd.com.
Okay, well, terrific. Well, thank you very much for being my guest again today and taking time out of your busy schedules. I really appreciate it, Paul and Kate.
Thank you, Kim, for everything you are doing.
You're very welcome, and I'm so excited to meet you next month, Paul, at the Burnout Symposium in New York. So I'm putting a plug in for that as well. That'll be awesome. And so in closing, to move the needle in healthcare, we all need to raise our voices and we all need to care about each other. We already know that doctors need to care about patients. Patients need to care about doctors too. So stand up, doctors, and let's stand up for doctors.